line. As soon as you're ready to start recording, let me know, and I'll just do that for you.
We're ready.
Okay, let me put the recording on.
This conference is now being recorded.
Okay, well, I want to welcome all of you on the teleconference today. We're going to do this in like in a question and answer aspect. Are each of you that are on the line, are each of you utilizing the 4-day process in your practice?
Yes, I am.
Is that
Zero.
And are you having any difficulties or any problems?
Not so much with the 4-day process. I like the way it's laid out, especially like the brain-body diagram and the pamphlets. I think it's an excellent educational process. My questions relate to something that is encountered in the 4-day, but it's really more about care plan recommendations.
All right, go.
Okay. There's actually two. I did a talk a few weeks ago. A patient came to the talk, or a prospect came to the talk, filled out the survey, and reported pain level of 8 to 10 at worst, fibromyalgia, as well as stenosis. So low back, leg pain, and all the fibro symptoms. She came to the office a couple weeks later, and I did the first test. And when she returned, she said that since the test, she had no symptoms at all. All the symptoms went away from the one test. I still did a second test, and she'll be coming back later this week for another visit. And I'm already wondering, gosh, how do I construct a care plan for someone whose symptoms totally went away with the first test?
Okay. Here's the question that you have to figure out. How long are those symptoms going to be staying away by doing one test?
Yeah, that's a great question. I'd like to know. I was expecting her to be symptomatic, came back for the second visit, but she wasn't.
And what you're going to have to tell her on the fact is that her body is still unstable, and that you're going to have to work on retraining that area to stay stable so that she can stay in the condition that she's in, which is without those symptoms.
Right.
So on a normal basis, how many visits would you describe for?
Based on what I know of her history and based on her x-rays, and again, I understand that with NRC, you don't base recommendations for care on x-rays. You look at x-rays to see if there's contraindications to care. But looking at her x-rays, she does have stenosis. And so, without knowing what her symptoms were, knowing her history and x-rays, I could at least be seeing her 3 times a week initially.
And that's exactly what you need to do. And how long would you usually... I wouldn't, just because she came out of symptoms early, I wouldn't change her treatment protocol for what you feel is right. Did I lose you?
No.
And the reason why I wouldn't do that is for several reasons. One, if she's had fibromyalgia for a long time, the possibility of a relapse is huge.
Yes.
So if you just go, oh my gosh, look, one test, she's symptom-free, we shouldn't give her the same amount of care that usually, that's not accurate.
Yes, right.
You're going to have to treat her until she's stable and has stability.
For the patient's experience and understanding and appreciation for what I'd be providing, patients usually look at symptoms as a way to gauge change. I guess I'd have to rely heavily on the re-exam findings every 12 visits.
That's correct. And that's how you need to sell it to her.
Right.
You need to sit down with her and say, listen, here's the situation. Your symptom went away after the first treatment, or I don't know, did you just do a test on her?
It was a test.
Okay. So your symptoms temporarily have abated after the first test. That does occur. And And the problem with that is most people at that point think, oh, look, I'm done, I'm better, I don't have pain anymore. And then the next step that you have to do is you have to get her to see how many years did that fibromyalgia take or the stenosis take, or how long did it take for that to accumulate before she had her first symptoms. And she's got to have that, like, aha moment, like that, oh, my gosh, I didn't realize that, you know, it was 20 years in the making, and that's the first time I got the symptom. I was been diagnosed, but it wasn't right then my problem happened.
Right.
And then that way you take 3 times a week to actually handle your condition, and the reason why is because your condition didn't start overnight. Yes, you're out of pain. The pain's been abated, but that doesn't mean that's long-lasting.
Right.
That's very short-lived. It could come back tomorrow. It could come back the next day, or maybe it's a month away. But if you put the program off for a month just because you're out of pain, when it comes back, there's 2 things that can happen. It's either going to come back the exact same or worse. Because the underlying cause never got handled. And if you don't handle that underlying cause, when things come back, it doesn't, generally speaking, end up being the same as it was previously. It tends to be worse because now it's been in place a whole nother month longer.
Right.
But I wouldn't change your treatment protocol just because she's out of pain.
That makes sense.
Okay? I would never do anything based off of complete, whether the person has pain or the person doesn't have pain, because that doesn't mean they're stable. It's just like when you do an adjustment. If you do one adjustment and they're pain-free, you absolutely know without a shadow of a doubt that that bone's going to go back out of place and put pressure back on that nerve because those muscles and ligaments aren't even stable enough to hold the bone in place and keep it there.
Right.
You're working with the same thing.
Yep.
Did that help?
That's good. That's great. Thank you.
Good. Do you have another question? You said you had 2.
I do. And this is about the construction of care plans. In the manual, the 3-ring binder, there's quite a bit of reference to care plans. And there's one paragraph stating that more recently it seems best to recommend care plans 1 month at a time. But what I hear when I talk to doctors that have been doing this work for quite a while, it seems like everybody is still recommending the full care plan on day 4, whether it's 60 visits or 100 visits. So I'd like clarification on what is really being recommended currently.
I may have to ask Colette a question. Colette, did we change the paperwork in there?
Actually, they can do it however they prefer. If it's easier for the doctor because he has not been ever selling prepays before, if it's easier to confront and swallow, or if he feels that the patient will be more comfortable looking at it a month at a time, you're welcome to do that. Dr. Kempton did pilot that in his clinic just to see if it made a difference in terms of the patients taking care and how well they did. And he did it one way, the full program, and his associate did the other, and he found that it made no change whatsoever. So it's up to the doctor's preference.
All right.
And I did something similar. I gave someone a full treatment plan, and then I broke it into quarters, and I gave them an option of 1/4 of the treatment plan because I wasn't 100% sure what kind of results they would get. And I thought, well, here's a starting point. It's better than nothing.
Yes. You know, obviously, you can do it in any form or format that works best for you. And if you have a patient who comes in who needs 100 visits, and you're over there...
Good afternoon, Dr. George speaking. Hi, Bob.
You're over there with the aspect of concern that they're not going to start under care, then you're absolutely right. You shouldn't do the whole 100 visits in one chunk. Because what will happen is when you sit down to go over this treatment plan with this patient, they will not close because of your hesitancy. and you will sound kind of wishy-washy with them, regardless of what's coming out of your mouth or the fact that you're saying everything perfectly. If you have any reservation whatsoever on the treatment plan, it's going to come across to that patient, and the patient won't start, and you'll go, what did I say wrong, or what did I do wrong? It's not what you said or what you did. It was how you felt.
Right.
And that part's very important for everybody to understand, because that's the number one aspect you have to handle before you even go in to even close the patient under care is yourself and your own thoughts. You have to be able to sit down with that person in front of you and know without a shadow of a doubt that exactly what you're prescribing is exactly what they need, so that you can close them under care with 100% confidence.
Yep.
And that's why you can do it either way. If you're not comfortable doing the whole thing, and then you're more comfortable with, doing it in a month at a time, then you can do it in a month at a time. You just have to realize that every month you have to do another sales or another close.
Right.
And that's why you have the old-timers not doing it that way, is because they find it easier to just close them one time and keep them coming versus trying to close them every month.
Right.
All right, so do I have some other questions? All right, no other questions. Are any of you getting stuck anywhere where you find out that, if you're doing the test, they don't come back, or you're doing the test before the consult and it's not working properly? So none of you on the phone are having that issue. So, Flint, since you deal with this kind of group all the time, what's the most common issues you see that patients have?
I think the most common issues that doctors call in with, hold on one second, I'm going to try to mute that caller. Okay. The most common issues are bridging someone over from a test in the office to the exam and x-rays. And then someone, one of the things is doctor's own consideration that the person can't afford it. And then someone not following through with the full 4 days. Those three issues I've had questions on.
Okay. Sorry about that. I had to write each one of those down so I can address each one of them. So let's just take the first one. So if we take the first one, getting a person from a test to an examination, there's a couple aspects that could be occurring here depending on how you're doing the test or depending on how you're actually handling the first day. If you bring the potential new patient in and you do the test first before you do the consult, I'm going to suggest you do it the opposite direction for several reasons. First of all, I have to ask, does somebody have me on a speakerphone? Hey, Doc, do you have me on a speakerphone? A lot of feedback going on the phone. The first thing is, if you're doing a test and then you're trying to handle the consultation, what you're looking at is you're having some complexities as far as the patient is concerned for twofold reasons. When they come in the office and they think they're just going to have a test, you have to understand that people with fibromyalgia have been suffering for years, and they do a lot of testing, and they do a lot of collecting of data. And if you don't penetrate the person to get them to want